Most patients eligible for osteoporosis screening by DEXA do not undergo such testing. An article published this week in AJR explored the use of photon-counting detector CT with novel spectral analysis of localizer images for osteoporosis screening for low bone mass and osteoporosis in patients undergoing imaging for various indications. I'm Andy Rosenkrantz, editor-chief of AJR, and I'm here today to discuss the article with its senior and corresponding author, Dr. Francis Baffour, Associate Professor of Radiology at Mayo Clinic, Rochester. Dr. Baffour, thanks for joining us.
Thank you for the invitation. It's a pleasure to be here.
To start us off, can you tell us how you've gotten involved in research in photon-counting detector CT?
So my journey into photon counting CT started during my radiology fellowship, where I had the fortune of working with incredible mentors who were deeply involved in pioneering new CT technologies. With my focus on musculoskeletal disorders, I saw the potential for photon counting CT to essentially revolutionize bone imaging, and it's been fun being a part of the early development and contributing to advancing this technology, which, as we are all seeing in radiology, has had a significant impact on how we approach imaging.
Yeah, you've done a lot in this space so far, with, I imagine, more still to come. So getting now to your current study, why is adherence with DEXA screening so low?
So osteoporosis screening is recommended for women who are, older than 65, or for those with risk factors that put them at risk of low bone mineral density and fractures. We found that DEXA screening is quite low for a variety of reasons, which include factors that relate to healthcare access at places with DEXAs, financial constraints, and sometimes a lack of awareness of screening among the patients and even their healthcare providers. And many of these patients who go untested may benefit from an alternative test, such as, the localizer image from a photon counting CT, which is essentially a topogram.
And this is certainly an important issue that you're trying to tackle. The article goes into much detail as to how bone mineral density values and thus T-scores were obtained from the photon counting detector studies. For purposes of our discussion today, and I know this may be tough, can you explain for us in about a minute the basics of how this method all works, in a nutshell, so to speak?
So to obtain the bone mineral density values and T-scores from these exams, we use what is called the spectral localizer image, which functions essentially just like the topogram radiograph of a conventional CT, except for the fact that these spectral localizers have spectral information in them. The spectral data is what we use to separate the image into a hydroxyapatite map and a water map. Then we place regions of interest on these images to capture density measurements of the vertebral bodies, which are then adjusted using the density of the background soft tissue from the water map. Once we have the final bone mineral density values, we then calculate T-scores based on a reference population. This conversion to T-scores is important for us to classify the bone mass according to WHO standards for osteoporosis.
And with that background in mind, you ended up looking at 51 patients who had both photon counting detector CT and DEXA within about 1 year. Your method correctly classified normal versus abnormal bone mass in 46 of those 51 patients, with an error in the remaining 5. What may have led to those classification errors?
The misclassifications may be because of issues related to differences in patient positioning between DEXA and the photon counting CTs. These subtle differences in how the patients are aligned on the scanning table may alter the area that's measured and potentially impact the bone mineral density calculation. Another important issue is that for this study, the photon counting CT analyses were done manually by placing the regions of interest in the spectral localizer image to capture the bone density values. And so minor inconsistencies in how we select these regions can lead to variability in the measured bone mineral density and therefore in T-score classification. Overall, these small variations are not a big deal in some cases. However, for those bone mineral density values that are close to the T-score thresholds, separating normal bone from low bone mass can shift these patients across classification boundaries.
So that's still about a 10% error rate. Do you think that's good enough to support using your method for opportunistic screening?
Dr. Rosenkrantz, a 10% error rate in classification accuracy may still be considered acceptable for opportunistic osteoporosis screening, especially in cases where traditional DEXA screening is unavailable or underutilized. We found that this photon counting CT method has a strong sensitivity for detecting abnormal bone mass, which suggests that it effectively identifies patients at risk for low bone density or osteoporosis.
And do you have ideas for future research as to how to possibly improve performance?
So, for clinical adoption, it would be essential to refine this technique to minimize misclassification. We found that manually placing these regions of interest on the photon counting CT images introduces variability. And so, automated software for these ROI placements, similar to what is done with DEXA, can improve consistency and reduce this human error. This will enhance the reliability of the DEXA calculations. Additionally, standardizing patient positioning, like is done with DEXA, would also improve the consistency in BMD readings.
Sounds like we'll need to watch the literature to see what those directions lead to. Switching gears, researchers for many years have also looked at using so called quantitative CT for the same purpose. So maybe one could say that CT alternatives to DEXA have already been looked at to improve screening. Yet the article explains the challenges in the earlier methods. Just what is the issue in attempting to do these measurements with quantitative CT?
That's a good question. So quantitative CT can measure bone mineral density, specifically volumetric bone mineral density, which is arguably a more precise measurement than the aerial bone mineral density that DEXA provides. However, the WHO standards for diagnosing osteoporosis are based on T-scores that are derived from aerial bone mineral density, not volumetric bone mineral density. This means that the BMD that is derived from quantitative CT cannot be directly applied to WHO criteria in the same way as DEXA. The PCD CT approach using spectral localizer images addresses this specific issue because we can directly measure the aerial bone mineral density very much like DEXA, and this aligns more closely with the WHO osteoporosis definitions. It is important to mention, though, that the ACR does provide some reference cutoff values for volumetric bone mineral density that can be mapped to osteopenia and to osteoporosis.
So basically, photon counting detector CT, but not quantitative CT, provides the data sets to give aerial measurements rather than volumetric measurements, if that's correct.
That's correct.
So now the article states that the prototype software was used to process the spectral localizer images and obtain aerial bone mineral density values. How did you access this software? And are those methods something that readers could use today for any photon counting detector study?
So the Mayo Clinic has a collaborative research agreement with the manufacturer of this photon counting CT, which gave us access to this prototype investigational software to use for the material decomposition and bone mineral density analysis. Since this is a prototype, it's currently not available for general use.
And last question, are you currently applying these methods in practice, whether for osteoporosis screening or other clinical applications?
So we're not currently applying these methods in clinical practice. These results are quite promising as an opportunistic screening tool for osteoporosis, but the routine day-to-day use will need to be automated given the operator-dependent steps. So for now, ongoing research and software development is necessary before these methods can be applied broadly for osteoporosis screening and for other clinical applications.
Dr. Baffour, this is an interesting study, and thanks for joining us today and discussing it with us.
Absolutely. Thank you for the invitation.